ones, okay? So that's the reason why. We're going to go through this after this. It's 116 slides, but again, it's a lot of pictures, okay? Lots. Like I said, we're going to talk about acne. We're going to talk about dermatitis, rosacea, hydradens. We talked about milia the other day. Then we're going to get into staph and pseudo and AKN, EIC, so epidermal cyst, and we're going to talk about the pilar cyst, okay? So we're going to get into these things, and we'll start first with acne. Multifactorial disease is the pilosebaceous unit. So that was sweating glands is what feeds into the acne that we have out there, okay? Onset with puberty, variance in severity, both sexes, not just one. It can happen to both. Some hereditary tendencies. So usually, if your brother or sister grew up with it, once you get to their age, you're probably going to have it too. Patient profile. So we see there 89% are those youngins, 12 to 24, and then it breaks it down lower and lower. So that is there, okay? Etiologically, 3 components. So we have excessive sebaceous gland secretion. So those sweat glands push it out. We can have pilosebaceous duct obstruction, so it gets trapped, right? We know we have these that they're open or they're closed. It depends on which etiology is into that. But then we can get that inflammation due to bacterial colonization. So not only is we getting some of that sweat glands reproducing some of sebaceous, we can have some of the bacteria that build up into there because you're taking them to Golden Corral and they love to eat all that stuff, okay? So that is how that happens. Proliferation of Propionibacterium acnes, okay? That's just the appropriate term for that. Breaks down to sebum to free fatty acids, which are irritating and cause inflammation. So that's what the bacteria is doing as it's in the buffet. It's one of those pathogenesis of acne showing how you can have some of the early comedone, you can get later inflammatory process once you get all of that bacteria in it. And a key word is in on that next picture, nodule, okay? Nodule is the determination of what type of an acne is. Is it mild, is it moderate, or is it severe? Nodules is the key component. Nodules is the key component to what it is. Again, there we go, non-inflammatory. So we got that open, we have the closed. Once we get that inflammatory into process, it'll start to develop into some of those papules, pustules, and then there they are, the nodules. More pictures. So we see that just the non-inflammatory, so the closed and of the open. But then we get into that inflammatory. So you get those papules, pustules, nodules. And then you see there how it breaks it down into those 3 things. And at the bottom of this list, you will see it right down here at the bottom. Nodules. You will see that. I promise you. This one that is mild has 0 nodules. This one has 1 or 2 nodules, and that's moderate. If it's 3 plus, then that's severe. The nodules is the key component to which classification this is. Typically a straightforward clinical diagnosis based on presentation. How does it look? Damn it. Okay, so we got to see those things to help us determine there. Differential diagnosis, of course, is going to be the things that we're going to talk about after this. So we're going to get into acne rosacea. We're going to talk about folliculitis, and then we're going to talk about that PFB, right? Pseudofolliculitis barbae. Philosophies of treatment, patient-centered. What have they tried? How long have they tried? We can know what the medical history is of it. How long has this been there? Do you have some of the family history? You know, social-wise, like what are some of the things that can have that, okay? Remember, these 12 to 24 teenagers, this is also some psychological stuff, right? Are they embarrassed about it? Like, is it causing them to feel ugly? Is it causing them to have some of those issues associated with what he or she looks like? Of course, with everything, we're going to use the benign stuff first. Okay, those are those things that you can see at Walgreens, CVS, Walmart, Target. Like, you can see all of those over-the-counter things that are out there that oftentimes people try that first because they have parents, mom, dad, hook me up. Okay, but of course, we're always going to, reevaluate, reassess, treatments that are out there. Type and number of lesions, direct treatment. Again, nodules, nodules, nodules. Management all patients. Skin care modification. Mild soap and water frequently. Mild exfoliation. So washcloth, buff puff, mask, peels, lotions, glycolic acid washes. Okay, oil-free, no makeup. Okay, we want to avoid those occlusion that could be covering that up and have that build up. Okay, no oil-containing creams to face hair, no hats. Avoid stress, caffeine, sugar content foods. Leave your monsters alone. No problem avoiding stress in puberty. It's not easy. I was there 30 years ago. I'm old. All right. Comedogenesis. So these are those medications that are those first line things, right? So we've got that the comedone as of the target. So we can use retinoids, benzoyl peroxide, salicylic acid, azelaic acid, alpha hydroxy acid, and isoretinoin. Okay. What's the proper of the name of isoretinoin? Accutane. Okay, so that's the Accutane. Again, us in this room are not going to prescribe Accutane. We'll start on some labs as we're sending them over to dermatology because they have to get into all of that birth control stuff. They got to monitor the liver. They got to do this and that. Yeah, bye-bye. Okay, so Accutane, referral. So if I was saying, you've already tried retinoids, benzoyl, antibiotics. You've tried all that kind of stuff, and the only next thing that can happen is Accutane. What are y'all going to do? Refer them. Okay? There we go. We see some of that acnes of that pseudo stuff. So antibiotics, retinoids, benzoyl peroxide. If we're having excessive of the sebum production, so that sweat glands are overproductive, yes, we'll use some of those retinoids, but we oftentimes will prescribe them or start them, especially if it's a female, on some type of an OCP. So we would use some of those anti-androgens, right? So that low dose OC to help reduce that thing, okay? And inflammation, again, those are those things. So those are those four of the breakdowns, and that's like the triad of what it is we would try before we're going to be sending them on and out. Again, that's that exact same slide right there. Is just breaking it down into that hobby picture that shows you what we would use for antibacterial, anti-inflammatory, sebaceous glands, yada yada. So again, we're going to talk about those four topics in each and of themselves. So comedonal, non-inflammatory. Okay, so this is non-inflammatory. We're not seeing all of that redness. We're not seeing nodules. We're not seeing that kind of stuff. It's mild stuff that is out there. We start this with retinoid. Okay, so if it's an open or closed comedone, then we start with that retinoid. Start low, go slow. Okay, again, tretinoin is there. I talked to one of your classmates yesterday who was asking about all of the things related to percentages. I am not going to test y'all on percentages. There are so many of those damn things out there. I just want you to know the name of the medication that you would probably want to pick. So I would pick tretinoin, right? I would pick that stuff out there, okay? You don't need to memorize 0.25% and okay? Don't have to do that because I'm not going to test you on those things. You will know what it is that you will use depending on that, okay? All right. Again, like I said yesterday, or it was the day before, I don't remember now. It's more about those groups, okay? Based upon where that location is at. Where is the acne? So what group would you use there? Okay, that is the key component. Where was I? Okay, yeah. Slow upward titration to avoid irritation and increase compliance. Apply at bedtime. Consider adding a benzoyl peroxide and or topical antibiotic like the benzocaine. That is a combo. So that's got the benzoyl peroxide plus that antibiotic of the clindamycin added together. Okay, so oftentimes that would be something good to do. Is if we're going to add it, hey, I'll give you one of these creams that has both of them in there, so you get that combo. Again, we're starting with the retinoids. But if they're already on a retinoid, then what could we add? We could add that combo to it to help it. Okay? Be patient. Remember, if they're closed, they can stick around for a little bit longer. So just be patient. Picture-wise, you see those open. Why is it open? Because you see the black dots, right? You can see that black stuff that is showing it. Closed, it doesn't look black. It's just closed. Non-inflammatory. So we see again, that's both of a breakdown. The picture on the left is open and closed is the other one on that lower lip. Okay, so that's that comedomal. Okay, now we're going to get into the mild, moderate, and severe. So this is, now it's got inflammation associated. So that's where those nodules are at, is with that inflammatory stuff. So here's mild inflammatory acne. Start with retinoid and or benzoyl peroxide or topical antibiotic. So we're just going to start with all three of those damn things. Alternate evenings for the first 2 to 4 weeks to allow the patient to adjust of that irritation. So it's not like you're just going to use it as a twice a day lotion as it starts. No, we're tapering it in so that we can get them up there. After follow-up, adjust dose as appropriate. Consider adding oral antibiotics if pustules remain at the follow-up. If we're going to do that, then we have Doxy, Tetra, Mino. Again, that's if you're following them up 4 weeks after you've already started on these things and it's still showing that, then we can add in one of those cyclins. Yeah, 3-month trial. Mild. How many nodules are there? Zero. It's not that. We see the inflammation, right? We see the redness. We see those pustules and other things like that there, okay? Again, with this one, we can start with the retinoid and or. So we could do, you know, retinoid first, have them follow up, then we can add in that kind of stuff. We can, you know, do that. We don't have to start that right away. We could still just start with that retinoid. However, if they have those 2 nodules and we call it moderate, we're going to start with all 3 right away. So if there's 2 nodules, we're going to start with those 3 right away. So topical retinoid, topical benzoyl peroxide, and oral antibiotic. So we're jumping straight for that oral. So Doxy, TCN, Mino, those are those cyclins. Of course, if those 2 nodules are stubborn and they won't get better with these 3 added to them right away, The other thing that we could do is we could do some intralesional steroid injection. Again, that would be after we're following them up, you know, after some significant time. If they come back and see you after 4 weeks and those nodules are not going anywhere, they're still there, and there's still only 2 because it's mild or it's moderate, then we can look into some of that intralesional steroid injection. Again, if even that intralesional is not working, or even if you don't want to do the intralesional, let's go ahead and just refer them. Let's send them. Because that dermatology will be prescribing them Accutane, and Derm only does that. Why? Because of the fact that that medication has severe side effects. Tetragenic, right? So if that individual was pregnant, the baby could pass away of that. So the dermatologists put them on some OCP, or they do some other things if they're on the Accutane as well. Mood swings, it works, but there are those side effects that are out there, okay? They even have to sign up to that I pledge. I state your name, da, 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 da. You know, like they have to do all of that kind of stuff. They have to go through labs, and they have to have stuff that's done. It works, yes, but you have to pledge. Exactly what I just said. In women, BCPs, right? We need to get them onto those things there, okay? Other options, again, if Accutane isn't working, then the dermatologist, not going to be prescribed by us, will look into some of these other ones as well, okay? It's pretty much all I got to do is just show you the slide, because I ain't going to test you on it. So here's pictures. Moderate to severe. Moderate to severe 3+. Okay, that's those nodules that are out there. So what would you grade this one?
Mild.
Mild, right? I don't see any nodules. I see some opening of the comedone. I mean, but yeah. So that, like y'all said, non-inflammatory. So that's, you know, just some open comedones. What about that? Again, mild.
Inflammatory?
This young man, yeah, I'd say he's got about, I mean, there's some of those things there, but I can only see 1 or 2 that are right there on that lower chin, so I would call that moderate, yes. Her, severe, right? She is severe. So she's got nodules of the forehead, of the chin, of the cheeks. So she's got that there. So I'm going to get of an HCG. I'm going to get some labs, and I'm going to send her to dermatology so she can go pledge for what she needs to be having. Again, they're severe. So nodulistic acne, nodule cyst, they get so severe that even if they do go away, it's still going to leave that scarring behind that individual is going to have for the rest of their life. It's always going to be there, even when they're old. Okay? So, severe, 3+ nodules, face, neck, chest, back. Usually a family history. So, my mom had this, my dad had this, my brother has it. They, tried some of that typical treatments, didn't work. Often embarrassed, suffering, missed work, school, depression, anxiety, isolate, like they try to hide just because of how they feel that it makes them look. So there you go. That is that severe. That's up there on all of the face, but you can also see this individual's back has all of it on there. That's acne conglobata. And we're going to talk about it down in a bit. You can just see how those nodules have bursted and they're into ulcerations, and it's no bueno. More of that. Rosacea fluminis. So it started off with some rosacea, and then it flared and became even more there. That is ouch. Again, management-wise, dermatology. Bye. If she were to walk in looking like that on the very first visit with me, yeah, I'm gonna walk you to Derm myself. Let's go over there and hang out. Okay? So, Accutane works by reducing size and activity of the sebaceous glands and normalizing keratinization. Very effective control and long-term remission. Significant side effect profile though. Not only that, but the dermatology can also use some of those intralesional steroids. But that last picture of that female, intralesional steroids are like, you would blow her up. That's everywhere. As I spoke before, all of that Accutane, that overview, right? So it will work on all 4 of those targets that we discussed, as well as nodular acne, recalcitrant acne. Those are things there. Overview wise, right, they need a 6-month follow-up time. Discontinue any tetracyclines or topical retinoids and vitamins, especially vitamin A. That we're not going to be using that. Once the dermatologist jumps into Accutane, they're not going to be using any of that other stuff, because it's only going to be the Accutane that is there. I told y'all that if I'm going to be sending someone over there, I'm going to, get of an HCG if it's a female, but I'm also going to have them already start to complete some of the labs prior to their appointment, even with that. Specifically, CBC, UA, LFTs, lipids, and of course HCG. Okay, review labs before that. So this is you helping out the dermatologist so that they can prescribe it that day when they see them for the first time. They already know what these labs look like. Repeat labs before each follow-up visit. Women's will have that HCG every month, and then 1 month also after DC because of tetragenic. So 2 methods. Again, this is Derm stuff, okay? This is Derm stuff. I'm just pointing out some of the things that I would want y'all to do before you take them to Derm. Ask about family history of IBD. IBD is one of those things that is associated with it as well. We talked about the family history. We talked about, ethnicity, yada, 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 yada. Yes, bro.
Is Derm going to put them on the birth control, or is that still going to be on us?
They will put them on that. Because you are pretty sure that they're going to be put onto Accutane, but the dermatologist has to make that decision. They have to decide if it is that I am going to jump into that. Okay, well then that's on them. They have to do the OC. Okay? All right. Patient's instructions. Emollients, moisturizers. Again, these is all Derm stuff, okay? Lubricate for lips. Watch for mood swings changes. Ugh. Avoid alcohol, damn it. Dispense only 1 month. Cannot donate blood. No bueno. You want me to take that damn thing and I can't have a shot? Shit. If they were to become pregnant, then of course we're going to have to stop them on that medication. That's why we check that monthly, just to make sure that it's not happening. If they're having some of that signs of that ICH, okay, so they're having headaches, they're having stuff that with the over-the-counter stuff is not working, then that would be some reasons that this could be secondary to the Accutane. Of course, we're looking into their anxiety, depression, and all of that psych stuff out there. So mood swings, of course, we always ask SI and HI regardless of even if they're here for some Mobic. I'm still going to ask about SI, HI. So those are those things there. Okay? So is this mild, moderate, or severe?
Severe.
Severe, absolutely. I just heard one of y'all say it. That conglomata, right? That's that thing that just looks like it's that. Good job, because that's exactly what this is, okay? So that is us. We just discussed specifically about the non-inflammatory stuff, so that's that open or the closed. And then we broke down into mild, moderate, severe, and we talked about the nodules and the ways that we could do the treatments, right? If it's mild, we're going to start with a retinoid, and then when we see them back in 2 to 4 weeks, we could then add some of the benzoyl peroxide or the clindamycin. We can add that in, okay? If we're seeing them moderate, let's just automatically jump to all 3, okay? If those are not working, what are we going to do next? We're going to order some labs and send their ass to Derm, okay? So that Derm can be the one that is up and over all of this to control that. All right. So now here's some of the breakdowns into some other things out there regarding the patient in and of themselves. So adult female acne, women in mid to 20s or late 30s. Obviously, this is hormonal sensitive, flares up with their cycles, right? So the menstrual periods can progress it on. They can be pregnant, and so they start to have some of the acne that is associating with that. Few tender lesions, slow healing, okay? So this is specifically related to only those adult female acne that is mostly hormonal sensitive. This is all about that estrogen. Very inflamed red papules, comedones, occasionally small non-scarring lists. Location is a chin and jawline. Chin and jawline. Management-wise, we're going to put them on some oral contraceptives, spironolactone, tretinoin, erythromycin, if it's having that strong anti-inflammatory action. So if the stuff up atop isn't working, then we could get into some of that mycin. Again, oral contraceptives, why? Well, because we want to suppress that hormonal stuff. So we want to suppress the excess ovarian androgen production. Spironolactone, so that's that androgen receptor blockade. Again, that's just one of those other things out there that could be used. We want to control the hormones when it comes to adult female acne. That's of the jaw and chin line. Something else out there. So here's the perioral dermatitis. So this is a clinical presentation, most common in young women, mildly itchy, right? So it's pruritic, recurrent, so it can come and go back and forth. Normally fair, delicate skin. Morphology-wise, we can see, right, small papules and pustules, typically combined to the chin and nasolabial folds. Pustules on cheeks adjacent to the nasolabial folds, occasional red and scaly. But on the fold right there, we see clear zone around the vermilion border. So as you can see, right above that lip, it's clear. So it's all pissed off and mad up around those nasolabial folds, but you got that clear in here. And the reason why I point that out specifically with this picture and what the statement's there is that we're going to get into some more of the dermatitis that is in those same areas, but that clear zone is not with those ones. The clear zone is with this one. So that clear zone around the vermilion border is specific to the perioral dermatitis. Etiology is unknown, but we know that it does have some things due to association of use of moisturizing creams. Patients may have tried self-treatments with topical steroids or benzoyl peroxide, but those things could be making it worse because they thought that it could work. If that's what they've been doing with those benzoyl peroxide or topical steroids, tell them to stop. Discontinue facial moisturizers and that. And if we see that border, that clear zone, and we're pretty damn sure that it's perioral dermatitis, we're going to prescribe doxycycline. Doxy is a good medication. It's used a lot. You see there, sometimes it can require a longer course. Once clearing is achieved, taper for additional 8 weeks. So we'll just break it down into a lower dose and then just taper it out, okay? Doxy. There's another picture of that. Y'all see that clear zone, right? More clear zone. Otra vez. It's there. Okay. So that's that perioral dermatitis. Acne rosacea. We talked about that earlier this week, speaking about how we can have that rash that's on those upper cheeks. Etiology. Specific etiology is unknown. However, you see that it's right down there. Demodex folliculorum. What is that? It's a mite. It's a mite. I told your class leader that I didn't know if I was going to be here earlier because I was doing a phase 2 remediation with one of our students who's all the way out in Landstuhl, and this was one of the questions that was wrong, and I brought it back up because of the mite. One of the treatments that is oftentimes used is flagyl, metronidazole, because that will then take care of the mite and get it away. So that's one of those things. Like I said, y'all aren't going to get that test though, so lucky. But I can move them into this. All right. So morphology-wise, erythema, papules, pustules, telangiectasis, swelling of the cheeks and forehead, and then once it gets to severe, you're going to start looking like a clown because that nose is going to blow up and it's just going to look like no bueno. Again, like I said, rosacea, fair-skinned people usually have it, right? So we're talking about the phototypes of 1 or 2, maybe 3. Happens in those high sebaceous activity areas, so mid-face, so that malar rash, which is of your upper cheeks. It could involve the eyelids. Others we'll talk about won't be on the eyelids, but this one can be. Chin and forehead. They've got triggers, they've got flushes, they've got things that if they do that, they'll start to feel it and be like, ah, damn it, here it goes again. Those things. Alcohol, hot spicy foods, hot drinks, caffeine, climate, exercise, emotion, stress, sun exposure. It can burn or can sting. Mid-aged causes some embarrassment, right? Because they know that if it's a family get-together or having a party with their classmates and they're having some bourbon and then their face gets all red and swollen, what the hell? What happened? Okay? So there you go. Mild to moderate. I talked about how we need to avoid those triggers. Sunscreen, that's in bold. Medication-wise, I mentioned to y'all flagyl, right? So metronidazole. That's active against that mite. We can use some azelaic acid. We can get into vacycline. We can get in those things if it's severe or if it's resistant cases. Refractory disease, refer to Derm, because there's isoretinoin, right? Accutane is on there as used. If they do have that severe rhinophyma, so they got that clown nose, that's big and huge, that will, again, dermatology, because they could do some of a surgical treatment of that to suffice. There's that mite. We see that malar area, so of the upper cheeks, but he also has some of it onto of his lip, right? He doesn't have that clear zone. He can have some of that up onto his forehead as well. Same. this one starts to have some of that rhinophoma that's starting to develop. That one's got it bad. Even worse. Okay? So those are those things. Dermatology it is, sir. Homemade acne, acne cosmetica. So small non-inflamed papules or comedones in patients who apply products that increase plugging. These Sephora people, damn it. Oils and creams. Locations can be on their forehead, temples, sides of the face. Okay? Sparring of the sebaceous areas. So this is not in all of those sweat gland areas. These are just those other words where they're putting stuff onto them that is aggravating and pissing off the skin. So that's why this is happening. So what are we going to do? Stay away from Sephora and Ulta, okay? Stop all oils and creams. Let's use some of that benzoyl peroxide. Let's add of a retinoid that they could take at bedtime. If that inflammation persists, then we can get into that some of that topical antibiotics like the clindamycin that we talked with our mild and moderate acne. There you see that homemade area. So now what else can cause this damn acne? Well, if they're on some steroids and they're using it too damn much, then they can start to get some of the steroid acne that develops, and that is then causing signs and symptoms here. This oftentimes will most commonly occur on the chest, the neck, and of the back, but it can also be on the face, it can also be on the arms. Follicular papules and pustules, uniform size and systemic distribution. It's not going to leave any scarring yet, but yeah, that's that overuse of the steroid. Sudden onset, 2 to 4 weeks after treatment with PO corticosteroids. So it's PO, this is not topical stuff. This is if we have them on some of the oral steroids that's then manifesting into the acne. Teens, adults, itchy, not a contraindication to continue or future use of PO corticosteroids. So if it happens, but they need the steroid to be alive, they're just going to have to deal with it. So we're just going to be doing some of that stuff, okay? We'll give them some stuff. If we can stop the steroid, then of course we're going to discontinue that. But if that steroid is more needed for something of an other underlying disease or process, then we would have to stick with that. If we're going to keep that up, then we can give them some of that topical treatment with benzoyl peroxide and or sulfacetamide, sulfur lotion. If it's itchy, then of course we're going to use some of that Atarax, Benadryl. It should disappear and go away without any scarring, but it's one of those things. Again, steroid acne, if you have to be on the steroid, this is one of those things that you're going to have to go through because you need the steroid for some underlying disease or disorder. Any of y'all wanting a break? I've been talking for 40 minutes. Are y'all good?
Push.
Okay. I ask that all the time, but if one person raises their hand and says, out, then it's going to go that way. Just letting you know. I'm not
Peer pressure.
I'm not horrendous. Talked about the milia, right? So that's that baby thing. That's those of the epidermal cysts without openings, usually related to some sun or of the age, right? We know that sometimes we can see this with those infants. As they're growing up, it fades away, but it's one of those things that are out there. Again, tiny, white, pea-shaped papules, asymptomatic, solitary, multiple, most commonly on the face, especially around the eyelids. Can occur with anywhere. You could use some of the retinoid, tretinoin, for several weeks until resolution, but oftentimes it doesn't need to happen. That's more of the reassurance, letting that individual know that this is benign, okay? So that's milia. If it's malaria, that heat rash, that's what we see mostly with those babies as they're born. So you can see that there of that right temple, looks like it's going up and over to the forehead. Some of it looks like it's up and under that hair area, upper cheeks. Milia ruba, so it's reddish. Prickly heat or heat rash, so that's that sweat retention. Hot humid weather, profound sweating, common in babies, less than 1 week after birth. Overdressed, if we got them on one of those anti-pee plastic covers on the bed, then that could cause that heat to just get onto their skin if we're not covering it up like we should. Stinging or paretic. Again, remove them from that warm environment, cool compresses, some of those antihistamines, but it's self-limited. It will resolve on its own. So there's that heat rash. Now we're getting into some of the stuff. More stuff. Hidradenitis suppurativa. That's that chronic suppurative scarring disease of skin and sebaceous or subcutaneous tissue. Okay, usually this is some type of tendency for scarring, acne, hyperkeratosis, or apocrine glands with secondary bacterial infection. Oftentimes we see this in some obese individuals who are having this happen to them. Again, with that obesity, we can see this in their axilla. We can see this in their groin, so suprapubic or anal, or up and underneath of the breast. It's that extra skin type of a comedone. 20s to 40s, female a little bit more than males. Obesity, chronic, they hurt. It is painful and debilitating. Mild, severe erythema, cysts, and abscesses. So that's why they hurt, is because it is some type of an abscess that is having that stuff in there that's just hurting. If it is some type of a double comedone, then you can see that black head with 2 or more communicating surface openings. So it's got open things to where that fluid or that pus or that yeast-like stuff is in there, just protrudes and it comes out. You can see how it will spread a little bit because it'll start to develop with time some of those sinus tracts. So it'll just be distributing itself through up and underneath of that skin. And it's going to cause scarring. Like once it's there, they're not ever going to forget it, okay? There we go. Produces cord-like bands of scarred tissue. Major trigger, I guess Habib says that this is oftentimes associated with some smoking. Like some of these individuals, they can be obese, smokers, whatever. These things is a part of a trigger. Mild disease will do some of a long-term antibiotics. So tetracycline, doxycycline, emycin, Klein, like those things are there. Hot compresses. If it's a large cyst or abscess, then of course we're going to IND it. And then we can use some of that intralesional steroid injections for smaller cysts. If it's extensive, okay, I talked about how we have those cysts and we have those sinus tracts, we have those scarring with some type of an active disease or something, then of course you can do some of the consultations because they will need to see derm or surgery or somebody who is going to have to excise these things. And of course, extensive disease of hidradenitis suppurativa is a referral for some Accutane. So talked a little while ago about some of those double the comedones that build into those sinus tracts. That's why, because you can see those openings there, that it's spreading through. It's like a tunnel, and it's going up and around of that area. You see that abscess and cyst. You can see some of that scarring that's going to be there for the rest of their life. Again, axilla, another axilla. That was showing it pre-graft and then after graft. Yeah, that's what it looks like after. You can also have this in the groin, right? So that's down there in the vulva area. You can see those of some on that left side. You can see that open comedone that's over there. So there's some of the tracking there and of both sides. Some more up and underneath of that abdomen, but you also have it into those tracts. That anal area can occur there as well. So that's that hidradenitis suppurativa. We talked about from our beginning process, we would give some of those tetracyclines or those medications to treat these things. If that's not working, then off you go into the wild blue yonder. Y'all know I was in the Air Force. I have that song that is in my mind every night I sleep. Okay. We got about 30 slides left. Are y'all good?
Oops.
All right. It's a Friday, and I know that Lieutenant Colonel Gendron loves to go as early as I do, so he'll probably be in here with y'all at like noon or something. Then you'll all be gone. All right. Staphylococcus folliculitis. So it's folliculitis, so this is an infection process of the hair follicle that this one is related to staph. So lone or more commonly grouped small pustules, mild to moderate surrounding erythema, located around the face, around the nares, and the lower face. Chest or anywhere hair follicles are present, so it can spread and get moved into those other areas where you have hair, right? So scalp, groin, you know, it can get onto legs and arms and stuff. Infection around follicles by Staph epidermis or Staph aureus. Staph aureus is one that we're going to talk about a lot in Block 2 when I'm going through all of the bacterial stuff. Staph aureus is one that, not a good guy, okay? Associated symptoms, so tenderness. Low-grade fever is uncommon, but it can be there. Injury related, so they shaved there or they had some type of a trauma injury that, you know, affected that. Complication of occlusive topical steroid therapy, so they're not using anything accurately. If persistent and recurrent, possible nasal carrier, so that got that staph that's always up in there and then spreading it around. They've had some contact with URI sinusitis, or it's y'all without using any of the PPE or anything like that. Okay? Mr. Stoufflet hasn't seen a patient since 2017, so it's not me. Well, I do RTA with y'all, so I guess that kind of counts a little bit because it's a vagina and a penis, so I don't know if you want to call it that. Y'all are gonna like it. Y'all are gonna like it. Y'all are gonna like it. All right. I think that's like 3 weeks before graduation that we take y'all down to Moreno Clinic, and then you'll be in of a group that will go into one of the male exam rooms. Us instructors show you how to do it all, and then y'all do it all, and then you switch, and then you go to the other one, and then you do a pap smear, breast exam, da 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 da. They get paid good money, and it doesn't matter how many times they get it done, but they get paid regardless of how many. So you can have it done 15 times, or you can have it done one time, and you're still going to get paid the same. It's not fair. It's not fair. I'm never going to do it. When I retire from this job, I ain't going into that club. We have this one, like, so I always volunteer for it, and I raise my hand first so that I can get stuck with the man, so I don't have to go through the crickery stuff. And there's this one, he's been here since before I got here in 2021. So he comes in 3 times a year and I always sign up for him. So I already know everything he's got, so I don't have to be shocked when I see something crickery. But yeah, anyway. Y'all see it one day. Y'all see it one day. All right, so management of this staph folliculitis. So we've got that isolated eruption. So if it's isolated, then we'll use some of the Bactroban or the clindamycin. So we're getting into that topical antibiotic. If it's extensive, then we're going to have to get into the PO stuff, right? So we can give them some of dicloxacillin. If they have a penicillin allergy, which it could say in a question oftentimes, then we can't use dicloxacin, we would have to use cephalexin. Okay? Recurrent or persistent, then we're going to get into some more things. So clindamycin, if it's on that nair area, then we'll use that Bactroban, mupirocin, wash the area with Hippocoons, change towels, pillowcase. We've got all of that bacteria that's attached to those things, and so that will be one of the things that we will have to do. Okay, almost there. PFB. So we know that this is that foreign body reaction to hair. Basically, you've got that hair that instead of it being sticked out, it curls back and up under that follicle, and then that causes that infection process to happen. You all know that this can happen in any ethnicity or race, but most commonly this occurs with African Americans, right? We know that we have seen, being active duty military, we've always had some of those shave waivers and other things. Y'all, 24-3 last semester, I threw it out there, but they told me that the hair shaving stuff is about to go away in all services, and I was like, damn, that sucks. But yeah, so that is where this usually happens. So you get those razor bumps, okay? 50 to 75% of blacks, whereas the whites is only about 3 to 5%. So that's the reason why we've always had those shaving waivers. Inflammation, papules, pustules, post-inflammatory hyperpigmentation, so it looks, that. If it gets worse, if it's not getting treated appropriately, it can develop into scarring and the keloids. It can get, we're about to watch this one coming up next, AKN, it's like, it looks like like another body is growing on the back of a neck or something. It just looks cray-cray. Okay, beard area, axilla, you can also have this down on the groin. Modified shaving technique: hydrate, soften beard, wash with benzoyl peroxide, Aveeno shaving cream, shave with grain, bump fighter razor. Prescription wise, we would be using some type of a topical steroid, specifically group 6 or 7. So PFB, group 6 or 7. We could also get into some 2 or 3 if it's a larger lesion, only if it's necessary. Okay, so if I tell you that you already used some type of a low group and it's not working, then you could jump up into 2, 3. May add topical retinoid. Temporary profile for up to 3 months. Again, that was like the bullet that's associated with all of those profiles, right? Keep being nearly trimmed, no greater than 1/4 of an inch, no styling permitted. I'm gonna have to look in that again because I was told that that's going away, so I don't know.
Next one.
Laser hair removal can be, but of course that will be cosmetic stuff that they will have to go pay for themselves. I don't think Derm active duty does that, but that's what they look like. So those are those pustules that are popping up. That's a microscope look into it, so you can see that hair is coming out, but it's going back in. So it's a microscope look at it. Back of the neck. Shaving. I told you all about that one that looks like another body's growing out of the back of the neck or something, because that's acne keloidis nuchae. So this is almost identical. It's coincidence of PFB. And if it's so severe, then it'll start to build itself up, and no bueno. Chronic scarring folliculitis of unknown etiology. Process same as PFB, coexists with PFB. Nape of the neck more prone to keloid formation. So don't forget that I tell you, it looks like another body is growing out of the back of the neck, because that is the most common location of AKN. Nape of the neck. Of course, management-wise, no short shave haircuts. If postular or exudative, we will culture to see if there's any type of a infectious process that would need some of that antibiotic like TCNs. 3-step plan for control. Topical Clinda, fluocinide, and T-retinoid. Those are those things that are put together with all three. If it continues, then of course, we're going to refer them to Derm. I would refer them to Derm regardless right away if I see it when it's starting off, okay? They can do those oral steroids, injections, therapy. They can do excisional surgery, okay? So if they were looking like that, and I can see it's on the nape of the neck, and you are, having some of the PFB that's happening on of the front stuff, they coexist with each other, so I'm automatically going to send you out, because that is going to get worse. It can even start looking like that, okay? And that's intense. All right, we're almost there. 12 slides. EIC, epidermal inclusion cyst, derived from upper part of a follicle, so occluded and dysfunctional, implanted up and underneath of the epidermis due to some type of a trauma. That's what causes this cyst to occur. Follicle becomes filled with sebum and swells rapidly. So it'll have some of that pus, sweat. It'll be some of that, you'll squeeze it out and it looks like you popped a cyst that's filled with cray-cray stuff. I told y'all on day number 1 that if we're having some type of a cyst, not only is it the stuff that is inside of it, but it's all of the wall that builds itself up. So if I were to pop this open and squeeze all of this stuff out, but I leave that cyst wall there, it's going to fill itself back up. So you have to open this up and you have to scrape it out. The whole thing has to get taken out, or else they're going to get it back. And y'all, I promise, in phase 2, y'all will do at least one of these things, whether it's in the ER or it's derm or surgery. You will see how, like, you take those, not of the scissors, but of the groupers, and you spread it and open it all around that wall, so you separate them, and then you get that entire cyst out, and it looks like this. Hey, look, I got it. Like I said, round, protruding, smooth surface mass, soft, mobile, right? Few millimeters to severe or centimeters, visible but dysfunctional pore, face, neck, back, scalp, posterior lobal Scrotum, there's a one picture of the scrotum in this one, so you're going to see it. It can happen anywhere, okay? Typically don't occur until puberty, most common in people with oily, sebaceous skin. Acne-prone or family tendency persists. Typically asymptomatic. It's one of those things like, it doesn't really hurt, but what the hell is it? Like, is that cancer? Again, if this was protruding out and this individual smacks it or somehow it pops and it pushes out some of that cyst material, they think that it might be gone, but if that cyst is still living in there, it'll come back. Yeah, see, sometimes spontaneously ruptures extremity, but it will come back, resolve. Again, we don't have to treat them if it's asymptomatic and it's cosmetically acceptable, but the only thing to do is to excise intact if possible, may reoccur if capsule is not removed. If it's inflamed, we could put some of that triamcinolone, so that corticosteroid into that, and then I&D. There we've got one, cosmetic-wise. My younger brother, he's 2 years younger than me, and he's got one of these on his upper eyelid. And he always says, I ain't taking that shit off. It's my eye. Okay, it's up to you. You still look cute, Bubba. Again there, it's sticking out, right? Lower ear. God, that's going to take for hours. Okay. Last one, a pilar cyst. So this is that same exact thing as an EIC, but it's got a special name of pilar because it's of your scalp. The treatments and everything are exactly the same. Okay, it is just like a cyst wall and everything, but it's just on that sub-Q location of the scalp. Asymptomatic. Oftentimes they can notice that they're walking around and it looks like they're having a horn or something that's building up there, and so they come to see you. Produces a compact, homogeneous material that can calcify. So it's of that scalp, okay? It's not as common as an EIC, but it's like that. You have to excise them, opening them up, getting all of the cyst wall out and everything to come on out. So excision is the only treatment that is there. And that's what the pilar cyst looks like. That was 116 slides in an hour and 3 minutes. We talked about acne, right? So we broke it down into non-inflammatory. So we have open and comedomal, closed. Then we've got mild, 0 nodules, moderate, 2 nodules, and 2 and above, severe. Talked about how we can, have referrals of the Accutane and all that kind of stuff. Perioral dermatitis. What was that specific thing to it? That clear zone, right? So we can see that that area was not there. Acne rosacea. So that's that thing that is triggered by stress, alcohol, exercise, those things. We talked about how we can use some of that topical stuff, but we can also do some of the flagyl, of the metronidazole, because of that mite. Hydradenitis, we know that that is that cyst or abscess that has to be taken out. Miliaria, that's that heat rash for the babies. Staphylococcus folliculitis, that's that Staph aureus. PFB, AKN, that's worse. EIC, take it out. And pillar. Do we have any questions? Monday, I will be with y'all at 10 o'clock, and we will be doing the last lecture for block number 1. And then the following day, I'm going to be up here for the 2 hours talking about the review of everything that we went over. So I'm going to say it all again, okay?